Chapter 13, Bipolar and Related Disorders. Starting off with a case study. You are a registered nurse working in the behavioral unit of a Midtown hospital. As you enter the building near the ED to begin your night shift, you hear a woman at ED intake talking faster than anyone you've ever heard in your life. Her thoughts and speech are racing from one thought to another as she tries to explain something to both the ED nurse and the police officer who assisted her in getting here safely. And right here off the bat, we're definitely looking at a patient who's in a manic state. Symptoms of this manic state include extreme drive and energy, inflated self of importance, demanding to be seen first, drastically reduced sleep requirements, excessive talking combined with pressured speech, like they just need to get it out right now, personal feeling of racing thoughts, distracted by environmental events, unusually obsessed with and over-focused on goals, purposeless arousal and movement, and dangerous activities such as indiscriminate spending, reckless sexual encounters, or other risky behaviors. Bipolar disorder can be classified many ways. Bipolar 1 disorder is the most severe form, has the highest mortality rate of the three, and at least one manic episode. Bipolar 2 disorder has at least one hypomanic episode and one major depressive episode. So right there, you're looking at bipolar 1 as extremely more manic, whereas bipolar 2 is going to have more of the hypomanic and depression. Not to be confused with cyclothymic disorder, and these will alternate symptoms from mild to moderate depression for at least 2 years in adults, and could even have rapid cycling. The hypomania associated with bipolar 2 disorder is characterized by a low level and a less dramatic mania. It tends to be euphoric and often increases functioning, usually accompanied by excessive activity and energy. Continuing with our case study, as you wait for the elevator, you hear the officer explaining that the woman was driving erratically. When he pulled her over, he discovered she was not intoxicated, but explained to the officer that she had not slept in days. As the intake nurse asks questions, the woman keeps starting to answer, but then looks all around her, distracted by other patients, people in the waiting room, etc. You hear her say, okay, look, I'm bipolar. Your elevator arrives. Other bipolar disorders: substance and medication-induced bipolar, or bipolar and related disorder due to another medical condition. And these are patients that aren't necessarily bipolar, but they get that stress, they get into substance abuse, a serious medical issue, and suddenly they begin to take on a lot of symptoms of bipolar disorder. For the epidemiology, there's a lifetime risk of nearly 4%. Men and women have nearly equal rates of the condition, with severe postpartum psychosis a 4 times greater risk. Children and adolescents can have disruptive mood dysregulation disorders that can definitely turn into bipolar disorder as they get older. And for cyclothymic disorder, this would appear in adolescence and early adulthood, with a 50% risk of subsequent bipolar 1 or bipolar 2. Just as you arrive on your unit, you learn that a new patient is soon to arrive. You learn that it's the woman you saw downstairs. Based on what you've seen of this patient already and what she has said, what symptoms might you expect to see when she arrives? A. Catatonia. B. Expression of racing thoughts. C. Low self-esteem and tearfulness. Or D. Lack of interest in her environment. And only one answer really jumps out there, and that's going to be that expression of racing thoughts. B. Comorbidity bipolar 1 disorder. Nearly all anxiety disorders are associated with bipolar 1, affecting about 75% with this disorder. This would include things like panic attacks, social anxiety disorder, or other phobias. Other disorders may complicate clinical presentation or management of bipolar 1, things like attention deficit or hyperactivity disorder. All of these conditions are disruptive, impulse control, or conduct disorders. Substance use disorder can present in over half of those with bipolar 1. This is a serious medical condition. And unfortunately, these patients know that they're manic. They know that something's wrong with bipolar. And they're trying to self-medicate to reduce these manic symptoms themselves. And often that can just make things worse. For bipolar 2 disorder, 75% of individuals with bipolar 2 have a comorbid anxiety disorder. This can include things like eating disorders, particularly binge eating, or other substance abuse disorders, again, of them trying to self-medicate. Substance abuse disorders are, again, going to be very common with this cyclothymic as well. And they're trying to self medicate and subdue the symptoms. They can also have issues with sleep disorders, where they have difficulty going to sleep and staying asleep, and maybe using illicit substances to self medicate this way as well. And again, these are going to be very common comorbidities with attention deficit hyperactivity disorder, more common among children with cyclothymic disorder than with other mental health conditions. Continuing with our case study on the lady from the lobby, an assessment interview reveals that your new patient from downstairs, Miss A, 53, is an adjunct college English teacher who claims to also be a novelist. It's always the English teachers. She says that bipolar was almost inevitable. I grew up in a family of 5 girls with competitive, ego-driven parents. It was hellish. As soon as I got a scholarship, I ran as fast as I could to college, where I absolutely lived on coffee, books, and the drama department. I lost my job, but I'm a novelist now. Under risk factors, just like many of our other conditions, there's a strong correlation with that nature versus nurture, though this one's going to be a little heavier on the nature end of things. For some evidence suggests that bipolar disorders are more prevalent in adults who had high intelligence as a kid, particularly in verbal areas. For bipolar 1, there's a genetic similarity to schizophrenia. For bipolar 2, it's strongly correlated with major depressive disorder. And research findings show the major neurotransmitter imbalances and changes such as hypothyroidism. There's also environmental links to childhood trauma or stress. Neuroendocrine issues, environmental factors, it's always going to be somewhere on that nature versus nurture scale. Based on her history, which factors can you identify that may have an influence on Mrs. A's condition? That be A, biological factors, B, cognitive factors, C, environmental factors, or D, all of the above. And again, remembering back to her, she had that stressful childhood. It also sounds like she was extremely intelligent. So again, it's going to be D, all of the above. We had an wide variety of both genetic and environmental predisposition to this condition. Mrs. A further describes her childhood, a part of her life she finds particularly troubling. We all had to compete if we wanted attention. Dad played favorites, depending on our grades and talents. I was his favorite, but I hated it because it made my mother hate me. How could she compete with her own daughters? Sometimes in high school, I scared myself with how much I just wanted to hurt them both. Sometimes I still do. I'm writing a novel about my life. It's won a lot of awards and it's not even finished. I wrote to a famous actress about playing my role. I'm pretty sure she'd find my life highly interesting. A role of a freaking lifetime. Right off the bat there, from that case study, we're hearing a lot of grandiose delusional thinking. For our mood, we could assess her mood through an Altman self-rating mania scale, which we do have a link attached here in the slides. And keep in mind, their behavior can often be manipulative and demanding, splitting, and a need for staff unity. Early diagnosis and proper treatments help is very necessary with this condition. They're at extreme risk for suicide attempts, alcohol or substance abuse problems, marital or work problems, as they just have a major difficulty maintaining relationships. When assessing these patients, you're going to see a lot of bizarre and out of the ordinary thought processes and especially speech patterns. Pressured speech is very common, where they just can't get each word out fast enough. A lot of circumstantial and tangential speech, loose associations, where they're reading into a situation way more than they should be. A flight of ideas where it's just one idea after next, taking a subject and just running with it. A lot of clang associations, meaning they're using rhyming words very unnecessarily. And as far as thought content, they're going to have a lot of grandiose delusions. Like that patient in our case study, she's writing a novel half written that's won a bunch of awards even though it hasn't been written. She's written to a famous actress who's going to play it. And they'll also have a lot of persecutory delusions, meaning they feel like the world is out to get them and a lot of people are out to get them when that's most likely not the case. We're also going to want to be assessing cognitive deficits very closely as well. Everything from those manic episodes, the history of their psychosis and psychotic events, Chronicity of the illness, meaning how often do these symptoms appear. Poor functional outcome of how well are they functioning out in their day-to-day life? Are they able to maintain a job? Are they able to maintain relationships? Early diagnosis and treatment are going to be crucial to prevent this illness's progression. Left on its own, they'll become more and more frequent and only get more extreme as it progresses. And for medication selection, should consider not only the efficacy of the drug in reducing mood symptoms, but also the cognitive impact of the drug on this patient as well. I know we've talked a bit about mood stabilizers, which is going to be very necessary in this case. Everything from lithium to considering the anticonvulsants we talked about as well, such as Depakote, which, while those anticonvulsants are used to prevent seizures, they can also be very effective at helping to reduce symptoms in lesser severe levels of bipolar, less severe cases of bipolar. Miss A keeps mentioning she's writing a prize-winning novel about her life and is pretty sure a famous actor will want to play the role of herself. What type of symptom is she displaying? That be A, flight of ideas, B, tangential speech, C, loose associations, or D, grandiose delusions? And in this case, yeah, it's those grandiose delusions. These are manifested by a highly inflated self-regard. It's apparent in both the ideas expressed and the person's behavior. People with mania may exaggerate their achievements or importance, or state that they know famous people. This patient makes some unlikely and uncomfortably boastful claims that her novel about her life has already won a number of big prizes, and that a particular famous actor will want to play the role of herself. What are some problems that can be avoided from our case study, or what exactly is this patient at risk for? Your very first thing you should be assessing is going to be suicide attempts. Suicide is very, very common in these conditions. And again, when it comes especially for mental health nursing, safety and identifying are they a risk to themselves or others is going to be a top priority. Also be assessing things like alcohol and substance use problems on the outside. Are we going to be expecting this patient to go into any withdrawal? What kind of issues are we going to be expecting from that? Also be assessing things like marital and work problems and development of other medical comorbidities. As often these patients in extremely manic episodes will go long stretches without eating. What other medical conditions has she picked up secondary to her manic states? For self-assessment, hopefully that's not the case for any of us today. Discomfort is going to be common. Enhance your professional ability by sharing and acknowledging uncomfortable feelings with staff or nursing faculty members. Honestly, these can be very difficult patients to work with. They're going to be very difficult to talk to, very difficult to have open up honestly with you. And honestly, they can be very frustrating to deal with. And you got to remember, you're the nurse. You need to be very patient with them. For assessment guidelines, again, that danger to self or others. We've assessed are they suicidal, but also think of things like picking their roommate carefully. Obviously, we can't just give a private room to everyone depending on the facility, but we can have put a little bit of thought into who we're pairing this patient with, as she may be difficult for them to room with. Think of the need for protection from uninhibited behaviors, the need for hospitalization and inpatient treatment, especially while we get her on medication, get her stabilized. Also assessing other coexisting medical conditions, assessing her family's understanding of her condition if she has family in her life. For our potential nursing diagnoses for this patient, things like risk for injury, risk for violence, sleep deprivation is going to be a big one. It's these manic episodes. They may not have slept for a long time. She may have built up an extreme sleep debt. Once we get her medicated, she may sleep a lot and catch up. Other impaired cognition, impaired concentration, any self-care deficits, feeding, bathing, dressing, and impaired socialization as well. Under our acute phase, prevention of injury, I know it keeps coming up, and it's going to keep coming up as we discuss bipolar and schizophrenia this week, of just the major danger that self-harm poses to these patients. Also, maintaining stable cardiac status, maintaining hydration and tissue integrity, making sure they're getting enough sleep and rest, and demonstrating some thought self-control as we get this patient medicated, as we get them admitted to the unit and stabilized. The team meets with Miss A to identify outcomes and develop a care plan for her. She asks why safety is such a big concern. Would that best answer be A, she's at risk for exhaustion? B, at risk for dehydration? C, she's having difficulty perceiving reality? Or D, all of the above? And again, it's going to be D. All three of these are distinct aspects of the diagnosis risk for injury. For someone in an acute bipolar state, she's going to have a lot of dangers and risks to her well-being. During the maintenance phase, we need to provide education of the disorder, how to effectively manage it, how to make sure you're remaining compliant, taking your medications on time, and not skipping days. Going off of their meds is going to be a big risk for this patient. Often we can get them admitted and we'll get them medicated, calmed down, stabilized, and then as soon as they're discharged, they do not follow through and they're going to be coming right back. And that's going to be a major problem we want to avoid. During the acute phase, we want to get the patient stabilized, medicated, and maintain safety while we're admitting them to the unit. They're most likely going to be admitted. If they're in this degree of mania, they're in this heightened manic episode, we're going to be finding a room and admitting this patient. Even up to considering options such as seclusion, restraint, or even ECT in very extreme situations. Once we have the patient admitted and stabilized, we want to be focused on preventing a relapse, limiting the severity and duration of any future episodes. Patients with bipolar often require medications over a longer period of times. It's not like we can just give this patient a pill of a lot of these mood stabilizers and it's all better. It's going to take time as these doses to build up and begin to have a therapeutic effect. Often it can take several days to weeks depending on the medication. And we also want to make sure we're supporting the patient and repairing their lives. We're getting them back to eating. We're getting them rest, recover, sleep, whatever issues. And this condition can be very wearing on the patient. We want to help them recover physically as well as mentally. During depressive episodes, that hospitalization is usually secondary to suicidal ideations, psychotic or catatonic signs, and medication concerns about bringing on a manic phase. As far as manic episodes, these hospitalizations are usually due to the acute mania that we've been talking, much like our patient from our case study. If we are admitting this patient in an acute manic episode, we want to make sure prioritize safety and impose those external controls on destructive behavior. We want to make sure this patient is well aware of the unit rules, setting firm boundaries, and we're doing everything we can to get this patient medicated, stabilized, while still providing for safety as we get them adjusted to the inpatient setting. Much like we've talked about in our therapeutic communication chapter, we want to provide a neutral demeanor, provide a firm and calm approach. We don't want to be aggressive. We don't want to go setting hard. We're not Nurse Ratched, but at the same time, we're not a pushover either. We're a firm, neutral nurse at the bedside who's setting firm boundaries while still empathizing with the patient and helping them to open up. Use short, concise explanations to minimize any potential for manipulative behaviors. These patients are going to be very, very manipulative. And also identify the expectations in simple, concrete terms of exactly what the unit rules and expectations are. At the same time, we do want to listen to the patient. We want to hear them out. We want to empathize. This has got to be extremely difficult for the patient. Hear and act on any legitimate complaints they may have. Also, firmly redirect that energy into more appropriate channels. There's going to be group therapies, art therapies. Try to redirect this manic energy into something positive. Continuing with our case study, although she is not aggressive, the treatment team finds Miss A bit hard to handle. She seems to have forgotten personal boundaries and is argumentative about every little rule. She asks one nurse if she can't please stay out in the TV room after lights out to watch a movie that starts at midnight, that she just has to see. What that nurse says no, she approaches the second nurse and says that the first nurse said it was okay with him. She's delivered to her room and the team has a meeting to improve the communication plan. This is going to be very common behavior, very manipulative, wanting special treatment, expecting special treatment, And we need to make sure that everybody's communicating, everybody is on the same page, and we're setting consistent boundaries. As far as maintenance, we're now got the patient stabilized. We're looking ahead on discharge, and we're focused on preventing relapse. Making sure we've impressed on this patient the importance of adhering to their medication regimen. We've also been providing this patient education and provided them access to regular and adequate sleep both in the facility, as well as explained the importance of that adequate sleep outside as well. We've given them the healthy nutrition. Hopefully they've caught up on any malnutrition they've gained from their manic episodes. And we're also not just sending them home alone on their own. They've provided them resources to contact while they're outside, whether it be more other providers, outpatient facilities, or community support groups. Under the health teaching, make sure we've provided this patient is aware of the recurrent nature of bipolar. Just because these medications are effective right now does not mean that they won't need adjustments in the future. Make sure that I can identify warning signs of impending episodes. And again, sleep, exercise, proper diet, all these can go a long way in preventing future recurrence. For teamwork and safety, these are going to be difficult patients. Make sure we're giving very accurate reports to the next nurse coming in. Make sure everyone's communicating about what's going on throughout the shift. Provide frequent staff meetings. Be very open. Make sure everyone's aware of what's going on with each patient. These patients can be extremely manipulative. Don't believe everything they tell them. If you have an open mind, but don't just take everything at face value. Make sure you're communicating with the other nurses so that everyone is setting consistent limits. If seclusion and restraint does become necessary, it's used as a last resort, but in some cases it is going to be necessary. Make sure you're following all policies and procedures to a T. Seclusion and restraint is a very common way for litigation and lawsuits to occur. You want to make sure you follow that policy very closely. You've assessed that patient, you have followed all documentation, and you don't want to leave any holes or any issues should it come up in the future. You have to explain it in court. As far as outside support groups where these patients could seek additional help as well after their discharge, there's the Depression and Bipolar Support Alliance. There's NAMI, the National Alliance on Mental Illness, which is a very large and extremely helpful organization. For evaluation, again, we want to evaluate these outcomes. We want to prevent recurrence. Make sure we've really impressed on them about adherence to the medication regime, resumption of functioning within the community, and achievement of stability, working on improving their family work and other social relationships, because often patients with bipolar can really suffer in these areas. And as far as pharmacotherapy and medications, we're going to be focused on both the agitation and mood stabilization. Lithium is a very effective drug as a mood stabilizer. It's the same heavy metal that's in your phone battery. It's indicated for extreme mood swings, bipolar disorder, but it also has certain considerations. We want to make sure we're monitoring those levels closely. We want to make sure we're maintaining a therapeutic level, and we're also teaching them about the dietary restrictions, that they need to maintain a consistent sodium level. You look at it within the body, lithium is processed as a salt. So say you go to the movie theaters, eat a bunch of popcorn. What do you got to do? You're going to drink a lot, and then you're going to go flush it out. You're going to go urinate. Well, in the case of a patient on sodium, if they eat a bunch of salt, when their body's flushing out that excess salt, it's also flushing out their lithium dose. At the other end, if they restrict salt completely, their body's no longer excreting sodium, meaning that lithium level can rise to toxic levels. We want one consistent daily sodium intake, and this is really going to help us titrate their patient's lithium dose so that they can maintain one consistent therapeutic level. Miss A is started on lithium. What potential patient teachings about this medication should the nurse provide? And again, the purpose and requirements of this lithium, its adverse effects, its toxic effects and complications, as we discussed. This is a metal. I actually knew working dialysis, several patients that were on dialysis had killed their kidneys because they We're still taking their lithium, but we're not following up. We're not getting levels checked. And long-term toxic effects of this is a heavy metal that will kill their kidneys very quickly. It's a very effective medication, but it also is not one you can just set it and forget it. It's going to take a lot of maintenance. We've got to get these levels checked frequently. We got to titrate that dose and watch it very carefully because we don't want these levels going too high or too low. Anticonvulsants. I know we've talked about this a bit as well. Depakote, Lamictal. If you're ever admitting a patient and you see they're on Depakote, they're on an anticonvulsant, and you ask them when was their last seizure, if they look at you funny and say, I'm not epileptic, they're using it as a mood stabilizer. It's not going to be it's going to be for less severe cases of bipolar. But at the same time, these anticonvulsants can be very effective mood stabilizers as well. Another class of medications we could be considering are our second generation antipsychotics. These are going to be especially beneficial during our acute phases when we bring them in. Things like Zyprexa, Geodon, Abilify. And every patient's going to be different. That lithium is a very old drug that's been very effective, but can we get the same results with a less invasive regimen, such as with one of these antipsychotics? Or integrative therapy. Omega-3 fatty acids have been shown to be effective in helping to reduce symptoms. Cod liver oil, fish oil. No evidence to support use in treating mania, though as an outpatient treating themselves, there is, much like St. John's wort, there's a lot of CAM therapies, alternative therapies out there that some people really swear by. Just like with all of these alternative therapies, we want to make sure we're documenting on our end. We're including everything they take on their med rec, both prescribed as well as over the counter. For brain stimulation therapies, the first one we'll discuss is going to be ECT. I know ECTs come up a lot, and while it can seem invasive, it is very, very effective. Major advantage of ECT is that it works more quickly than medication in improving these depressive symptoms. Usually start to show effects within a week, and most commonly used in patients who have bipolar disorder with severe levels of depression. Also, repetitive transcranial magnetic stimulation that we've talked about a couple times as well. Just like with many of our conditions, it's not just going to be one intervention. It's going to be medication therapy combined with psychological therapy. Cognitive behavioral therapy is going to be far and away the most common for almost all of these conditions, but we can also be including other therapies depending on the patient's unique needs, like family-focused therapy. Wrapping up with our last question here, which anticonvulsant medication might be prescribed for a patient with bipolar disorder? Would that be A, Depakote, B, Klonopin, C, Zyprexa, or D, lithium lithobid? And in this case, the answer is going to be A, Depakote, because that is the only anticonvulsant on this list. B is Klonopin. That is a benzodiazepine, which may be used for anxiety, but definitely wouldn't be our first choice medication for bipolar. C would be Zyprexa, which definitely may be prescribed, but it's an antipsychotic, not an anticonvulsant. And lithium, which again is a mood stabilizer, not an anticonvulsant. And anyway, that's all we've got here for this chapter. I'll see you in the next slide deck.